There continues to be an explosion of new and innovative therapies available for men with advanced prostate cancer. More recently, 2 different PARP inhibitors have been FDA approved for use. These 2 drugs are really the first in their class approved as personalized therapy for certain individuals with advanced prostate cancer. Stick around as we have a world-class expert in the area of targeted therapy for prostate cancer to tell us about these 2 new medications, as well as who may be eligible for this therapy. The show today is brought to you by our sponsor, the Prostate Health Academy. The Prostate Health Academy is launching soon, and this is exciting news. The Academy will be an essential community for individuals wanting to learn more about prostate conditions, connect with like-minded individuals, and improve their overall health. So the big question is this: how can men and those who care for them better educate themselves regarding prostate health, the conditions that affect the prostate, and the latest technology in managing these conditions? That is the question, and this podcast will provide the answers. On a weekly basis, we will be chatting with experts, innovators, and leaders in the field of urology, sharing useful information with the general public to improve their lives and increase their overall health. My name is Dr. Garrett Pullman, and welcome to the Prostate Health Podcast. Prostate Health Podcast is for informational purposes only. Nothing in this podcast should be construed as medical advice. By listening to the podcast, no physician-patient relationship has been formed. For more information and counseling, you must contact your personal physician or urologist with questions about your unique situation. It is indeed an honor to be able to introduce to our Prostate Health Podcast listeners today Dr. Emmanuel Antonarakis. He is a professor of oncology and urology at the Johns Hopkins Sidney Kimmel Comprehensive Cancer Center, as well as director of prostate cancer medical oncology research and the co-director of the Prostate Cancer Multidisciplinary Clinic there. Since 2010, he has been on the Johns Hopkins faculty as an attending physician and translational researcher in the Department of Oncology. His clinical interests include the management of prostate cancer, and his research focus has included the development of novel androgen-directed therapies, genetically targeted therapies, and immunotherapies for men with recurrent or advanced prostate cancer, and using germline and cancer genomics to inform precision oncology approaches. He is the author of more than 290 peer-reviewed research articles and several book chapters. Dr. Antonarakis, welcome to the Prostate Health Podcast.
Thank you very much. It's a pleasure to be here.
Well, you have definitely been a leader and innovator in the field when it comes to looking at targeted therapies for prostate cancer. Now, what ultimately led you down this path?
When I first started working on prostate cancer about 10 years ago, we treated all patients in the same way. We didn't use information about the patient's inherited genetics or their tumor genetics to guide our therapy. And yet, many therapies that we used targeted the androgen receptor, which one might call a targeted therapy. And so we were using targeted therapy without knowing it, but we were not very refined in our approach. So we first started to ask, what type of mutations or alterations in the androgen receptor itself can help to predict therapies. And then we moved beyond the androgen receptor to start thinking about other genes or pathways which may help us to select a better therapy for one patient over another.
Yeah, well, excellent. And so in May of 2020, the FDA approved 2 new agents, which were PARP inhibitors, which really were the first in their class approved as therapies for advanced prostate cancer. This has really ushered in a new era of treatment with targeted drugs. So for our listeners, what is a PARP inhibitor?
Well, it's a mouthful. It stands for poly-ADP ribose polymerase. You can forget about the jargon if you wish. These drugs rely on the fact that cancer cells have more disorganized DNA, in other words, more DNA repair defects than normal cells. Let me explain that a little bit further. The genetic material for every cell is the DNA that has become popular in our culture and the media. We all know that the DNA molecule is a double strand. So if you think of 2 strings kind of twisted on each other in a helix shape, we've all seen the pictures in the popular media. Those double strands can undergo breaks every time a cell replicates or divides. And that happens with normal cells. It also happens with cancer cells. But the faster that a cell divides and the more often that a cell divides, the greater these errors in the DNA, these DNA breaks that can occur over time. And cancer cells have a more disorganized DNA, more of these DNA defects than normal cells. So that helps them to survive on the one hand, but on the other hand, it can become a liability. How can it become a liability? It becomes a liability when we use a drug that causes that DNA damage to become even more catastrophic, resulting in that cell to die. So there are two ways that any cell, including a cancer cell, can repair the DNA damage. One is to repair both strands at the same time. The technical jargon for that is double-strand DNA repair. Or it can repair one strand at a time, which the jargon for that is single-strand repair. In cancers that are not able to fix DNA damage two strands at a time, they become addicted to and reliant on the single-strand repair mechanism. So they have to fix DNA one strand at a time. And the enzyme called PARP, P-A-R-P, is the one that is involved in that single-strand repair. So if you inhibit PARP1 in a cancer that is not able to fix double-strand DNA damage, you create so much DNA damage that the cell cannot survive. The way that I sometimes discuss it with patients is a little bit of damage is a good thing. It helps the cancer cell to survive, but too much damage is a bad thing because that cell can no longer survive. So what we're doing is we are creating a situation where we are turning a little bit of DNA damage into too much DNA damage, so that cancer cell has no other option but to die.
Well, that's an excellent description there. And so with that FDA approval, what PARP inhibitors are currently available for individuals with prostate cancer?
So prostate cancer was the fourth cancer type that these drugs were FDA approved for. So we were lagging behind ovarian cancer, breast cancer, and even pancreatic cancer. But now prostate cancer is the fourth tumor type that we can use these drugs in. The FDA has approved two particular drugs. The first one is called olaparib, also known by the brand name of Lynparza. And the second one is rucaparib, which goes by the brand name of Rubraca. Both of these drugs are oral. In other words, they're taken as pills, so you can take them at home in the comfort of your own home. And they are not chemotherapies. People always ask me, are these drugs considered as chemotherapies? I tell them no, they are considered targeted therapies. They're targeting cancers that have a deficiency in these DNA repair pathways.
So which men with prostate cancer may be a candidate for a PARP inhibitor?
So the most effective treatment is in patients or cancers that have a genetic mutation in a gene called BRCA2, also called BRCA2. Now, this is another interesting story, and it gets back to a history lesson. The letters BRCA stood for breast cancer. So it's very paradoxical for a man to be told that he has a BRCA mutation in his tumor, and it's even more paradoxical for him to be told that he was born with an inherited BRCA mutation, because the first thing they say is, well, I don't have breast cancer, I have prostate cancer. And, I've always joked that if this gene had been discovered first in a male with prostate cancer, it might have been called PRCA1 instead of BRCA1. But the name has stuck and there's no going back. How common is this gene in prostate cancer patients? It's pretty common. About 10 to 12% of prostate cancers have a mutation in the BRCA2 gene. It's not always inherited. It can be acquired in the cancer, so it's not necessary that the person is born with it. But the inherited form is still present in about 5 to 6% of all men who have prostate cancer. Not 5 to 6% of all men, but 5 to 6% of all men who have themselves developed prostate cancer. So my rule of thumb is there is a 5 to 10% chance that the tumor or the patient have a mutation in the BRCA2 gene, which then makes them a candidate for these drugs. Now, there are a few other genes that are less common, and they have other names. One of them is called BRCA1, and then there are others, including ATM, like the bank machine, also one called CHEK2, CHEK2, and another one which is called CDK12. If you add these all together, you get to about 20 or 25% of all prostate cancers. So that's about a quarter of men with prostate cancer that can be offered these PARP inhibitor therapies.
Okay. We're going to take a quick break here with a word from our sponsor, and we'll be right back. There is some exciting news coming with the Prostate Health Academy. The launch is just around the corner, where we'll be opening the doors to the Academy. This will be an essential community for individuals wanting to dive in even deeper and learn more about the various technologies available to them for prostate conditions. In the Academy, you will be able to interact with like-minded individuals in the private community forum and have access to exclusive bonus podcast after-hours video content with experts, innovators, and leaders in the field. We'll also be keeping up with the latest evidence on a prostate-healthy diet and exercise, and creating a roadmap for you to keep you on track. For those that don't want to miss out, you can sign up for the waitlist at www.prostatehealthacademy.com. So you talked about some of the different genetic factors there, and for our listeners, what genetic testing is needed? Is this a blood or saliva test to really determine, who may be eligible for treatment with a PARP inhibitor?
Yeah, I'd like to respond to that question in two ways. There are two types of genetic tests that we can do. One is a genetic test of the tumor sample itself. And this doesn't necessarily have to be a new biopsy. Every time we see these patients, often they have had a biopsy already, either of the prostate gland, or they've had the prostate gland removed by surgery in the case of a prostatectomy, or in some cases, yes, they have had a lymph node biopsy or a bone biopsy. But any material that you can get your hands on is useful because you can sequence the DNA, the genetic material of the cancer. Now, this does not tell you if a particular gene was inherited or acquired. It just tells you that it's in the cancer. And there are two ways that it can get there. One is you could be born with it. It could be in every cell in your body plus the cancer cell. Or you weren't born with it, and over the course of your life, due to bad luck or some spontaneous mutation or just environmental exposures, the prostate cancer cell mutated out of the blue. And the jargon that distinguishes the two types of mutations is somatic mutation, which is found only in the tumor, versus a germline mutation, which is inherited. They're called germline mutations because they are passed by the germ cells, which are the ovary, the ovum, the egg, and the sperm. Now, the inherited mutations, of course, have to be tested either with a saliva sample or a blood sample. By the way, any tissue can be used, including a hair follicle, but in general, the most common sources of inherited DNA are the saliva, because you have cells from the inside of your cheek, which are being shed into your saliva, or blood, because of course the white blood cells can be used, not the red blood cells, which don't have a nucleus, but the white blood cells can be used to analyze the inherited DNA. So when I have a patient that comes to see me with metastatic prostate cancer, I typically do both. I order on the same day the somatic analysis from their most recent tumor biopsy, whichever one I can get my hands on. And I also send that patient home with a kit to give a saliva sample for the germline DNA.
So if some of these mutations are found, in reference kind of going back to, who may be a candidate for a PARP inhibitor, can it be in either sample, or does it have to be in both samples, the somatic and germline, or one or the other?
Either one is sufficient.
Yeah.
Now, I just want to clarify this. If you have a mutation that is present in your saliva, it is always going to be present by definition in the tumor. It has to be there.
Yep.
But the inverse is not true. You can find a mutation in the tumor that was not in fact inherited and was acquired. So some people would say that testing the tumor is enough because you capture both the inherited and the spontaneously acquired mutations. Other people like myself believe that doing both is important because although it may not help you any more than it would have for the therapy aspect, it will help you with the family counseling. And there are big differences. If you have a mutation in BRCA2 that's only found in your cancer, but you weren't born with it, there's really no chance that your family members could have it. However, a man is born with a BRCA2 mutation, each one of his first-degree relatives, meaning a parent, a sibling, or a child, each one of those has a 50% chance of having the same mutation. So there are clear family and genetic counseling implications. And by the way, those implications involve both sexes. So a man with prostate cancer who has an inherited BRCA2 mutation His daughters aren't safe. His daughters could have a risk of breast cancer and ovarian cancer, even though they don't have prostates, which is true. But his sons could have a risk of prostate cancer and also other cancers. For example, we now know that BRCA2 is linked with melanoma, with pancreatic cancer, and also, by the way, male breast cancer. Males have breasts. They can get male breast cancer.
Well, that's definitely very good, clarification there, and an important one too. And so, I know you'd mentioned in some of your patients that have metastatic prostate cancer, you'll begin ordering some of these tests. Are there any other points along the prostate cancer journey that you consider undergoing genetic testing, or typically kind of just more in those advanced situations?
So the two drugs that we just discussed, the PARP inhibitors, right now they have only been FDA approved, and they should only be used in men that have metastatic prostate cancer. That means cancer that has escaped from the prostate, spread to the bone or other organs, and who have failed or progressed hormonal therapies. And the technical term for that is castration-resistant prostate cancer. Most patients hate that term. They prefer the word hormone-resistant or hormone-insensitive. It all means the same thing. So to answer your question, I typically only recommend the tumor testing, the somatic testing that is, in patients that have metastatic prostate cancer. However, the chance of being able to help that person's family is still there, even if he himself does not have metastatic disease. So the germline testing from saliva, I routinely recommend this in virtually all patients with prostate cancer, even those who have a curable localized prostate cancer that they may undergo prostatectomy for or radiotherapy targeting the prostate gland. Because even though that man, he himself might be cured and he can forget about the cancer for the rest of his life, his family members, I think we owe it to them to figure out if they are at increased risk, again, not just of prostate cancer, but of other cancers, including breast, ovarian, pancreatic, and melanoma.
Well, thank you for that. And now when you sit down and counsel your patients regarding potential initiation of a PARP inhibitor, what are some of the benefits as well as the risks that you discuss with them, side effects in regards to PARP inhibitors?
Yeah, the studies have shown that the PARP inhibitors delay the time of cancer progression and they prolong the life of patients, the survival. That is great, but it's often not enough for a patient to take a new drug that may have side effects. So in addition to delaying a cancer growth and improving their length of life, I do believe that these drugs help the quality of life. In patients with bone metastases that might be painful, these drugs have been associated with pain improvements. There's also a whole bunch of quality of life improvements that have been shown to become better when you take this drug. Now, as we mentioned before, another advantage or selling point is that these drugs are taken by mouth. They're pills, so they can be taken at home. They do have to be taken every day, but I like to tell patients that this is similar to a blood pressure medication or diabetes medication. It's a chronic drug. You take it daily, but it will keep your cancer in control, at least for a certain amount of time, and does not require intravenous administration, which is a big advantage to many patients. The drugs are not without their side effects, even though they are not chemotherapies. The most common side effect actually is nausea, and about 15 to 20% of patients experience nausea. There is a trick, and that is if you take the drugs with food or with a snack, the nausea is much, much less or not present at all. Interestingly enough, and I would never recommend this as a dietary measure, but they are appetite suppressants. So patients typically lose about 5% to 10% of their body weight because their appetite is just not what it used to be. And that also goes hand in hand with the nausea. They're just not in the mood to eat as much or as frequently as they were before. These drugs can also affect the blood counts, specifically the hemoglobin level, which we call anemia, and the platelet count. And some of these patients might be at slightly increased risk of bleeding or bruising. They also have very mild but important side effects on the kidney and the kidney function. Using a blood test called a creatinine should be measured carefully for these patients while they're taking these drugs. And then these drugs should not be used in men that have partners of childbearing potential without the use of barrier contraception, for example, because there is a risk of teratogenicity, in other words, fetal defects in the partners of men that take these drugs.
Well, thank you for sharing that. And so in conclusion, any final thoughts today for our listeners?
Yes. First of all, we'd like to thank all the patients that participated in the clinical trials, because without the trials, these drugs would not be available for widespread use. And, it takes a very brave person to do a trial. If you ask a patient, what's your main motivation? There are people that, of course, say, I want to get the drug. But many people, in fact, most say, I want to help others. I want to help society. And many people actually say, I want to help my son or my daughter, because this might lead to a breakthrough that helps the next generation of potential cancer patients. So I'd like to thank them and also encourage new patients to consider clinical trial participation. You're not going to be a guinea pig. The way that I view it is you're going to be given access to a potentially new drug and maybe a life-prolonging drug that other people don't have access to yet. So you'll be able to get it first. Of course, there are risks that have to be considered when you do a clinical trial, but in many cases, the benefits may outweigh the risks. The second is that if you are a man who does not have a personal history of prostate cancer, but you have a family member with either prostate cancer or breast and ovarian cancer, please consider undergoing inherited genetic testing to see whether you are at higher risk of developing prostate cancer. The screening guidelines for detecting prostate cancer are different and are more intense if you have a genetic mutation, for example, in BRCA2. And so even if you yourself are not diagnosed with the cancer, but you have, let's say, a father with prostate cancer, a sister with breast cancer, I would recommend for that patient to undergo the genetic testing. It is being relatively routinely covered now by most insurance companies, and you don't have to have a personal history of cancer to qualify for the genetic test, because again, the second value is being able to prevent a subsequent cancer from occurring.
Well, I know I can speak on behalf of all of our listeners that we really appreciate you taking the time out of your busy schedule to join us on the podcast today. You've really enlightened us in regards to PARP inhibitors, ushering in a new era for targeted therapy for prostate cancer. Thank you again for being a guest on the show.
You're very welcome.
Thank you again for listening to the Prostate Health Podcast. We would love to have you join our podcast Facebook group at www.facebook.com/groups/prostate health podcast, or just use the Facebook group search function and search for the Prostate Health Podcast and ask to join. We'll see you at the next episode.